Hi everyone, it's our pleasure today to present our ninth journal club meeting. This collaborative, successful meeting between our OrthoBEMA and our Egyptian Orthopedic Association. Today we will present two nice paper by one of our two UK Egyptian doctors. The first paper will be presented by our colleague Mina Abbas Haroun. It will be about reliability and validity of Wrightington classification of elbow fracture dislocation. And second paper will be presented by our colleague Hatem Osman. It will be about the open fracture patient evaluation. It's open study. So, Mina, if you can share from your side, please.
Yes, please. Just 1 second. Yep. Can you see my screen?
Yeah, we can see your screen.
Okay. Shall I start?
Yeah, start please.
Okay. Hello, hi everybody. My name is Mina Abbas Haroun. I'm currently working in NHS as a foot and ankle fellow in Cardiff and Vale University Health Board. I'm presenting today an article about reliability and validity of Wrightington classification of elbow fracture dislocation. It was done in August 2020, but published in August 2020, with affiliation to Wrightington Upper Limb Unit in Wigan, UK. The journal that was published in was Bone and Joint Journal, which is a Q1 with the impact factor 4.6, and citation count till now is 19. So in 4 years, there is 19. 5 years. There's now 19 citations, and yep. So let's see. So just I'm Kasaraini lecturer and assistant lecturer, and now I'm in Cardiff and Vale. So let's talk about reliability and validity, about the title itself. So reliability is to get the target like in a small area. So for reliability, to say something that is reliable. So when you hit something like for many times, it will be in a small area. So your target is in a small area. This is reliable, and validity is to hit the target itself. So like on the lower left side, this is reliable but not valid because they didn't hit the target. They are reliable, but they are not valid. Okay, so for our classification, for a classification to be used in orthopedics, it should be reliable and it should be valid. So for as an introduction for the Wrightington classification itself, so elbow fracture dislocation are complex injuries with high risk of poor outcome. So the existing classification often target individual structure, either the ulna or radius, but there is limited comprehensive measure for each classification that we have currently, which we'll talk about it in shortly later. So Wrightington classification offers anatomical based and 6 subtype models based on the coronoid and radial head involvement, with a suggestion of a treatment algorithm for each type. And the aim of this study that we're discussing today is to evaluate the reliability and the validity of this system using radiograph and CT data. So just to go quickly about the current classification. So as we said, there is no classification for elbow dislocation itself. So either the coronoid fracture classifications like O'Driscoll classification or Wigan and Mori classification, or there is radial head classifications as Mason classification or Hotchkiss modification, and there is the classification about the Monteggia variant, which is BADO, or Jupiter classification, Jupiter is like classification for type 2 in BADO classification. And there is another classification, which is ring classification. So they all manage like only an individual structure or individual type of classification with no algorithm for treatment. So that's why the Wrightington classification offers what is lacking in our classification now. And there is also the general, what we call like general description of elbow dislocation, either a terrible triad or the posterior varus dislocation, or the transolecranean dislocation, which is not a classification in itself. We just naming the injury about it, but there is no classification for that. So the Wrightington classification offers, as we said, this type of injury. So it depends on the column. So it divides the elbow in 3 columns. So the medial ulna is 1 column, the lateral ulna is the middle column, and the radial head is the lateral column. And when there is disruption in these columns, dislocation happens. This is the theory of the classification. And it divides the elbow dislocations into 6 types. So A, B, C, D, and B plus and D plus. And as you see here, there is a suggestion of each type, a treatment algorithm for each type. So quickly, so the subtype A is equivalent to the varus posteromedial rotatory injury. Type B, and with B plus is the radial head injury. So this includes the Monteggia variants and the transolecranean disruption. Type C is the terrible triad, as we know it. And type D is the distal ulna with again a Monteggia variant. So to talk about this article, so how to validate a fracture classification system. So this is like a paper done by Outbridge et al. Framework, which is also mentioned in our literature as a reference. So they used to say that a study or a classification is reliable. So it has to be having inter-observer reliability. So to ask, do different clinicians agree at this classification? And intra-observer, which means that one clinician assess the classification or the fracture type and identify it correctly within like a time frame. And this is measured statistically by kappa statistics. Validity, it should be easy. So it says, does it accurately reflect the real fracture pattern? So if say, I will say this is Wrightington classification type A. So is it actually type A or not? This is validity. And we compare it to a gold standard. As we see here, they used the intraoperative findings as gold standard, which is no one can actually argue about it. So, and also for a classification to be used, so it has to be in expert agreement, so all experts use it. And for it to be multi-central reliability, not just like in UK we use it, and when we use it elsewhere in the world they say that it's not reliable. So it has to be reliable in multi-centers, and to guide management, which is why we classify a fracture for management, which is the important topic in fractures. So as a method for this study, they included 48 patients and reviewed by 7 observers. There were consultants, fellows, and trainees. So they are different type of experience. So the imaging was that all patients had radiographs, and 44 had 2D CT, 39 had 3D reconstruction. Okay, so they sent so they give a CD with radiographs to each observer, and the observer should classify each group, as he says, by radiograph only, or by 2D only, or by 3D only, and they will remind him after 4 weeks to be reviewed again. So this will manage like the inter-observer, so 7 observers will do, and also it will manage the intra-observer, so each one will do it twice, one and with 4 weeks apart. It is blinded, so there is no clinical data, only the radiographs was in the CD. And they validated each classification, each type by the intraoperative finding, as we said before. So for data collection, so they, as we said, they blended the data and they sent they also mentioned what which viewer they use, software, which is EOA-OrthoBEMA. They measured the inter-observer by Fleece Kappa and intra-observer by Cohen Kappa, which is a statistical method, validity by for software, and they use the software of IBM SPSS statistical software to do the statistical part. And they use a significance threshold p-value of less than 0.05. And they used the Landis-Kocher criteria to like assess the kappa and the reliability between each observer. So if they found that it is less than 0.2, it will be slight agreement. And there is fair agreement if it is between 0.21 or 0.4, moderate agreement, substantial agreement, and almost perfect agreement if it is above 80. So like above 80% or above 0.8 in kappa means that it's almost perfect and they always agree about the classification. So demographic and injury types. So the mean age for the patient, the 48 patient, was around 49 years, 60 female and 60% female and 65% injured the dominant hand. Mean follow-up was 6 months, so from 3 to 18 months. So this data, I think it is not relevant to our study because we only assess the reliability, not the patients. But they mentioned these topics, and they also mentioned that these, because they have excluded the initial type was, the initial total patients was 60, and they excluded till it is 48 that were only included, and they mentioned that because that they didn't have the radiographs, sufficient radiographs to do it, so that's why they excluded it. So most common types that they found is type B plus, which is 33%, type C, also 33%, type B 23%. There were minor findings about type A and type D plus, and there is no type D, which I think this affects the outcome, but we'll discuss it later. Sorry. So about reliability, they found that radiographs have moderate reliability. But for CT, either 2D or 2D plus 3D, they found that they have substantial agreement about the classification, and also intra-observer agreement. So they found that radiographs are 0.75, which is moderate. Which is substantial. So they're all substantial except for the 3D, which is almost perfect. So now we see that the 3D CD significantly was better than the radiographs alone. But when comparing the 2D CT with 3D or radiographs, there was no significant difference between them, although 2D was higher than radiographs and lower than 3D, but there was no significant statistical significance about that. Validity and sensitivity. So for radiographs, when they compared, like if an observer said that it is type B, and they found intraoperative that it is type B, so this is the validity that they have. So they found that radiographs give 73% compared to 2D and 3D CT, it gives 87 or 86%, which is very high. So CT is more accurate than radiograph, and according to subtypes, so they also divided each subtype to see what is the validity of each one. So they found that B plus and C were significantly statistically significant between CT and radiographs. However, for B diagnosis, there was no significant, and other types were very few, so they didn't do a statistical analysis for that. So regarding the discussion, so as we said, the Wrightington system, which is done, Wrightington classification system, which is done by the Wrightington Wrightington orthopedic department, which are the one who are doing this study. So they have done the classification, and they have assessed the classification in this study. So they saying that it is reproducible and accurate, and CT imaging, as we mentioned, that it is superior than radiographs for diagnosis and classification. Comparison with other classification systems. So they mentioned the classifications that we mentioned above. So the individual classification for coronoid and radial head and Monteggia. They compared their reliability and validity to other studies which assessed this classification, and they found it's higher. And they also said that the classification included management and algorithm, which we discussed before, and it also it is applied for broad injury patterns. So they say that like the classification of Wrightington system is very good, and they promote that we should use it in our practice. So regarding the critical appraisal of this paper, so the same authors who designed the classification in 2019 are the same one who done the assessment of this classification. And I've got the article where they first published their classification, which is 2019. And followed by the article, same article. So this is one that is this is new one. So after, like in 2025, this is a new study that also are done outside Wrightington, and they actually said that the results of this article that we are currently mentioning is reliable, and they have done have same results as our study now. So for positive feedbacks, so the lead author, as we said, didn't participate in the observations, which is good, which is shows that there's no bias about that. Validity using intraoperative findings, which is great, and no one will have any problem or have any some sort of doubts about is this valid or not. So it is the intraoperative finding, so it is sure the best thing. They mentioned the reasons for excluded patients, as I said before, and they compared statistical significance between included and excluded groups. So they said that there is no statistical significance between the included and excluded group to strengthen their results. There are detailed statistical analysis, as we said. So everything they have done a statistical analysis for it, and they discussed it in the discussion. Literature review. So as we said, they mentioned most of the classifications that we use currently before Wrightington in order to say. So this is like a literature review, and they also mentioned in the paper that the observers of different experience level and different hospitals. So in the acknowledgement, they actually mentioned some of the participants as observers, and so this is also not blinded for us, and this is also give it a positive impact. However, for negative feedback, So as we said, first of all, as we said, not all classification subtypes were presented in this study. So there were like D types, they were not mentioned. So we cannot say that this is study is reliable. This classification is valid or reliable for type D according to this study, which is a negative feedback. Some data were irrelevant, as we mentioned, like patient age, and some. This is not about the patients itself. This is about the classification. So I think this data were irrelevant for this study. A small sample size of patients, so only 48. So this is only small size. Again, so this is few observers, so they only have 7 observers, and they, as we said, they mentioned 4 observers only. Okay, we didn't know who are the other observers and what are the levels. They just mentioned we have consultants, trainees, and fellows. But they mentioned that 2 of the authors were of the same institute of Wrightington. So it might be some bias and it might be against them. And also it is the affiliation, and this is the part that they are the original, they have done the original classification, and they have done this reliability to and validity study to assess the classification, which is like we can think about some sort of bias about it. But as I mentioned, that it happened after 5 years that another study in another center have actually confirmed their results. So as a take-home message, writing classification is valid and reliable tool for assessing elbow fractures, and they also help in guiding the decision making about it. They also confirm that the use of 2D and 3D scan is recommended for optimal accuracy in diagnosing elbow fracture dislocation. And in my opinion, the study is well structured and reliable, and also reproducible because it happens that it is reproducible, and some study also, as I mentioned, that give the same results. So I think this is a good study, and I think it will help to change my practice, and I will use it. This is my end of my story, my presentation. Thank you.
Thank you, Mina. I think Mr. Hashim joined us now.
Hello.
Yeah, thanks, Mina. Just a quick one. Are you aware of any validation studies who tested the reliability and reproducibility of this? I know that the Wrightington classification is used everywhere at the moment. To me, it's quite complex. I'm not an upper limb surgeon, so don't count my opinion in. But I mean, for the people who are doing upper limb, do you feel it's really reproducible? It's definitely valid.
For me, it's like, yeah, for me, it's like it is easier for me to say it is terrible triad than to say it's type C Wrightington. But because we all know about terrible triad, and we all know about this, I think like as many classifications that depend on column, like ankle classifications or tibia plateau classification, they need some time in order to like make everyone use it and be but for I think for now like it's good because it depends on, like, this is elbow classification, we will use this classification. So for elbow dislocation we use this classification for that, which is good. Okay, not like when we say, okay, this radial head is Mason type 2, and about the coronoid it is the odiscal 1, which is the medial part. We can like use a general term. So I think it's good, but
so validity is definitely there. So it's definitely guide the treatment, is definitely prognostic. So from Wrightington classification, you can say how this elbow injury is complex, how this elbow injury will, what operation exactly, what you need to fix, what you can ignore. So it guide the treatment, it guide the prognosis. But I mean, regarding the reproducibility, it could be in a more simple term, especially for juniors using it day-to-day practice in ED. So it was having a look on any revalidation, in a cross-sectional revalidation studies which looked into this to see if it's really reproducible everywhere or not. Because validity, there is no question. I'm sure it is valid. I'm sure it's reliable. But the point is, can we reproduce it locally everywhere? This is a question, especially with starting juniors. So it's difficult for seniors to understand it and retain it. So for juniors, it's quite a bit difficult.
Yes. Yeah.
But Mr. Hashim, if you are saying it is valid, but it's only one study assess the validity, and one of the two authors who did the validity for the study is two of the main authors. So
Yeah.
I think still early to see it's valid because actually
I think valid in terms of practice. So it is used already. So it's see the structure of the paper does make difference if the results are not a high yield results, but this is a high yield result.
Yes.
So it's definitely there's a lot of bias. There is no study without bias.
Yes.
But the point I mean valid is when this paper came out, all the upper limb surgeons start to change their language about the elbow fractures, both writing it in account. And it's definitely guiding the treatment, it's definitely guiding the prognosis. It gives you an option to explain to your patient what type of injury does he have, what you would be doing, what is the expectation post-op. So from valid point of view, it is definitely valid. Even there is some bias in the structure, I agree. So the problem of the reviewers, the problem is coming from one center. The problem is, as I told you just now, it doesn't have any studies because big studies like you inventing a new classification, you have to do a pilot study. You have to test the validity and reproducibility yourself. Don't wait for someone to do a cross-sectional validation study. But at the end of the day, it's used in practice day to day, and it is valid. And it is reliable because it definitely changed the practice in everyone's hands. It's changed the practice. But the question is, not everything valid and reliable can be reproducible. So as I'm asking you, if you are ST3, ST4, or an SHO, or can you give me the Wrightington classification when you stand in front of elbow fracture in ED? I don't think so.
Yeah.
You have to go read it, and you get my point. So the reproducibility is a big issue.
Yeah.
And I totally understand the point from the like where did they come from? They come from, it is a complex injury, and it's not a single bone injury. It's like 4 bones injury, and every bone has a different structure. Every bone has a different contribution to the elbow stability. So it's not a simple anatomical area. So it's expected that the classification will not be simple and will not be reproducible. But even with 2 reviewers, yeah, it's valid. Even if one center, yes, it is valid. Especially if you know that the center and the reviewers are big experts. So Wrightington is one of the biggest upper limb centers over the country. So they have enough traffic to come out with a classification because they see every day. They are a referral center for most of the north area for upper limb cases. So this is the point of validity, and as I told you, it's really did help in a lot of elbow fracture dislocations. But for me, as a senior trainee, but not doing upper limb, when I was doing the exam, was an easy job to get Wrightington right. I remember the column, I remember the colors, I remember the way I've seen the people who done the classification themselves. I've seen them working, but it is still for me a bit of a bit of chaotic.
Yeah, it's new.
yeah, this is the point. If it will answer certain knowledge gap, I will agree with you. But being it's first time for me to see this classification. We don't use this classification our trust, so I think it's more complex. Maybe if I used it once or more than 2 or 3 times, maybe more simple. But I think it's still little bit complex.
No, it is. It's not a little bit. It is complex, and it's definitely used only by upper limb people. I don't think it's used by general surgeons, and it's used in trauma meeting. It's used in upper limb MDT. It's not used in a daily practice in ED. That's a definite. You get my point. This is something you have to go back and read it. So it's not something you remember. It's not Gartland. It's not Powell. It's not. No, it's not. Definitely not.
It is difficult. Yeah.
Yeah, and I think this is only the only drawback in this classification is this. It's a bit complex, but as I told you, we can understand that because the area is anatomically complex. So guys, why not to share us in this discussion? Anyone who is doing upper limb can help us with his opinion. How do they find that the Wrightington classification? Are they happy with? we need the upper limb expert to just bob their head in and give us some clues in the chat.
Mina, please, can you go back to the slide of the classification? Can you keep it on the
just 1 second. Just 1 second. Yeah. This is the one. Thank you.
But when you see them explaining the classification, they have a more colorful picture. So they colored every column separately. So anteromedial, anterolateral facet of the cornoid and the lateral column. And though this is still complex, but they have a special picture with making an Gothic arch and showing you if the arch is collapsing from medial, collapsing from lateral, collapsing from center. So, yeah. Something like that. Yeah. Exactly. Yeah. Rami said it's not widely used. Definitely, because you both wasn't working the centrust. Where is the ad? No way. Hatem, where are you?
This is new.
We're running Cambridge, but I mean, where are you now? I need you to share your screen. You're going, coming, going, coming.
Can you hear me?
We can hear you, but we cannot see you.
I'm sorry, I cannot. I don't know what's wrong with my cam, so I'm so sorry. I'm going to present.
No, absolutely, don't worry.
Okay?
We need your screen.
So, yeah, shall I share my screen now? Just 1 second.
Unshare Mina, yeah?
Mina, please stop sharing.
Unshare, yep. Fine.
Okay.
Did you stop sharing, Mahina?
Yeah.
Can you see my screen now?
Yes, we do.
Can you see?
We can see. We can see.
Okay.
Shall I start?
Yeah.
Yes, please. Just make the screen presenter mode. Slide share from down, Hatem, right side. Yes. Right, yes. More right. No, more right. More right.
This one.
More right. No. Just after the line after this.
Yeah, okay, sorry, yeah, that's okay. Good. Yeah. So, hello everyone. My name is okay, shall I start? So, my name is Hatem Osman. I'm currently working as a senior clinical fellow in Addenbrooke's, Cambridge. Okay.
Hatem. It's not a slide share. Just put right click on the presentation. Right click. Should you a slide share? Can we see we can see your PowerPoint itself.
You can see it.
Yeah, from here. So if you go down, right side, 1, 2, 3. Yeah, push on that.
Yeah. Okay.
Doesn't go anyway. Yeah, you can go ahead. Go ahead.
Can you see it now?
Yeah, we can see it, but not on a slide share. But anyway, go ahead.
Okay, it's fine. So again, my name is Hatem Osman. I'm currently working as a senior clinical fellow in Addenbrooke Hospital, Cambridge. So first of all, who am I? I've been I'm born and raised in Alexandria and Victoria College, and after that, I've joined Alexandria University for Faculty of Medicine. Alexandria University, went to Birmingham University Hospitals. And currently I'm working in Addenbrooke's hospital in Cambridge. So I'm talking today about the open study. So I felt like it's better to just like recap some info that we all know, but sometimes we just do like a brief recap regarding this. So what is the open fractures? There is any type of fracture that's a direct communication with the external environment. The diagnosis is made clinically by assessing the size and of the nature of the external wound, as well as obtaining radiographs of the bone and the location of the soft tissue injury. We still, at the moment, we use the Castello type of open fracture when you describe that in the trauma meeting or you tell your consultants what you're going to see. So it's type 1, type 2, and type 3. And type 3 is being divided into A, B, and C, in which like the C, which has like a vascular injury and the repair.
It's not moving. So based on the slide by slide, because it's not slide share. So we still see Alexandria University faculty.
Yeah, sure. I don't know how can I do this. So
just click on each slide when you go to it.
Okay, fine. Sorry. So can you see this now?
Yeah, we do. Yeah, we see the picture of the open wound here.
Okay, fine. So as we have just mentioned that like the open fractures, it is just like fracture direct communication with the external environment, and we're still using the open and Castello one, in which type 1, type 2, type 3, and type 3 is divided into A, B, and C, in which C is having like a vascular injury, and type B is usually more than 10 centimeter with inadequate soft tissue to cover the periosteum. Type 3A is also the same, but there is adequate soft tissue. So can you see this now? Can you see my screen now, right?
Yeah, Hatem, we see it. So what you need to do, try to press F5. I don't think it will do the job. Anyway, so your presentation is clear to us, but not in a slide share. So you cannot just press the button. Yeah, exactly. Now you move to what's guidelines in UK.
Okay, fine.
So with every slide, just go press on the slide itself. You get my point? Exactly like that. Okay?
Okay, fine, good. Sorry. So what are the guidelines here in UK, so we can understand what are the standards of the practice that we do here in UK regarding the open fracture. So we usually got which is well known by the POST guidelines, and also there is PAPRAS, which is the British Association of the Plastic Reconstructive and Aesthetic Surgeons, also by the Orthopedic Trauma Society and the British Limb Reconstruction Society. So all of them have described which is called like the POST guidelines, and which that we are doing our daily practice here in UK all over the trusts, that we need to adhere to that kind of practice as a standard. So I felt like it's important to speak a little bit for the non-UK based surgeons, that what are the POST guidelines, because when I was back still in Egypt, when somebody's telling me you have to study about the POST guidelines, I wouldn't understand what he's saying. So right now, when you're in UK, you might be able to know that by heart, but this is POST guidelines, in which that it's have like guidelines which guide you again is the proper treatment and the proper standardization of every case. It's a different scenarios. So sometimes for open fractures, supracondylar fractures, spinal injuries. So it gives you standard things for treatment all over different aspects of trauma. So this is the slide for the POST guidelines. I'm not going to go through it all, but just like just a recap, because it's important in our study, because our study is just planned on the standard of that care of the practice in compared to the POST guidelines. So the first thing, that initial action we usually do here, if you are working in MTC or anywhere here in NHS, that they usually refer for you a patient with long bone or hindfoot, midfoot fractures to a place in which that an MTC which have an orthoplastics center. So it's not ortho only, it needs to be orthoplastics. This is a very important point, because most of our study will be dealing with such like referring the patient for a joint surgery between the ortho and the plastics. The second thing is local care accepted for hands, wrist, and forefoot and digits. And this is sometimes is being missed even for the guys working here in UK. Sometimes you don't need to accept the hand fractures, the open fracture, the wrist fracture, the forefoot, and the digits. It still can be managed locally. IV antibiotics, it's a very important aspect that should be ideally 1 hour after the injury. Also for clinical assessment, which is important for you as a doctor, for your medical legal, just to document and reassess the neurovascular status, follow the POST guidelines for the compartment and arterial injury, if you got an open fracture, it doesn't mean that you might not get in a compartment. You still might be able to have a compartment syndrome. Trauma CT, especially from the head and toe scanogram. I don't know, like I've been working in 2 MTCs. I don't know, like a major trauma centers. Sometimes they do not go for head and toe. They just like go from head up to the mid of the, like head until the pelvis, showing just like the mid of the femur. Okay. Also, they might be including angiography is if you feel that there is any vascular concerns. Wound handling before the theaters. This is an important topic that avoid many washouts, as we used to wash out by 9 liters of saline in the ED. That was our practice before we joined here. Actually, here you don't need to do any kind of washouts except if you are moving like glasses or something that may be hazardous or causing harm to the treating physicians and even for the patient. So only the gross things need to be taken out if you can see, but avoid many washouts. Apply saline soaked gauze occlusive film. You need to have a photography for the wounds. It's very important because sometimes some trust doesn't have that kind of imaging saving like in a secure way for the patient. So sometimes it's very important to have a photograph, especially for the wound. Ensure 24/7 image documentation capability. Am I doing good with for the slides?
Yeah.
Hello.
It's in operative planning and timing.
Yeah. Okay. Fine. So
It's
because
funny with you. So yeah.
I haven't heard anything, so that's why I was
confused.
It's fine. Regarding the operative planning, are we still in the post guidelines? It is a consultant, should be a consultant. It's not like ST3, it's not like ST6. It's a consultant. Orthoplastic planning is essential. It is very important for documentation. The debridement time, it's immediate for contamination and vascular compromise, less than 12 hours in high energy fracture, less than 24 hours in a low energy fracture. You can still do fasciotomy, as we do mention. It doesn't mean that you got an open fracture. It means that you don't have a compartment. You may still have a compartment syndrome, even if you got an open fracture. Fixation and coverage, internal fixation only if definitive soft tissue cover is available. Achieve soft tissue closure within 72 hours. MDT discussion required for salvage versus amputation. Amputation, if indicated, should be within 72 hours. I will come back to our open study, which is national evaluation of the open fracture management in the UK. This is the first large scale multi-center analysis for the open fracture across the UK. It was covering 1,175 patients across 51 hospitals, adhering to the British Orthopedic Association standards and highlighting the national practice patterns. Key metrics were including the antibiotic timing, which we should say it's less than 1 hour, surgical urgency and consultant involvement, fixation strategies, and wound coverage. The findings reveal a higher compliance with the prompt consultant-led surgery, mostly within the daytime hours at a specialist center, while identifying areas of improvement such as coordination of MDT between ortho and the plastics, early soft tissue coverage. Sometimes this has been delayed, and refined antibiotics protocol, because this is the people still not adhering to the antibiotic protocol after the open fracture. So what is the methods for the open study? As we do mention, it was in 51 UK hospitals across a 4-month period in 2021. All the patient was above 18 years with open fracture, but they have excluded the phalanges and isolated hand injuries. Data collection was facilitated via secure platform, ensuring robust input and audit tracking and export compatibility. The sample size was 1,175. The study was, as we do mention, 4 months, exclusion, isolated hand injuries, and phalangesis. So what is the results? The results was for the antibiotic administration, the pre-hospital was 22%, with a median of 1 hour 29 minutes. And this is not good, not bad, because it's ideally should be less than 1 hour, okay? But it's still like, it's good to have an antibiotics, which is 1 hour 29 minutes. In the ED, it was about 70%, which is median about 25 minutes from the radiograph. So it's really important to ask when you take the handover and from the like the ambulance crew to ask about the antibiotics, and don't ask just like if the antibiotics has been given or no. Just ask please about the time and just document that. There is some ward delays when the patient went to the ward, because we know that here in UK it takes time until the patient be transferred from the ED to the wards. It takes about 7 hours, almost 8 hours. And overall, it's about 82% of the patient received antibiotic before the transfer to the ED. For the wound documentation, there was 72% of the wounds had been photographed. So it means that 25% hasn't been done, which is legally binded that you need to have some photograph for your wound. 94% has been stored digitally, which is a good thing. Time for the surgery, it was about 16 hours from the diagnostic radiography. Complex wound operated earlier. Elderly patient had longer wait, because for sure they will be having more medical concerns, and sometimes it takes time from the medical team to just, due to long listing, they got to review the patient, and after that, usually the patient, the elderly patient, have been taken like blood thinners. So you need to consider that as well. 90% of the debridement occurs during the daytime hours. It gives you a clue, okay, that usually we don't go overnight, except if it is just like a vascular or need for an urgent one. Most of the cases has been operated, 90% has been operated on the daytime. Consultant ortho, that's why we are good, okay, has been presented in the 90% of the first procedure, or maybe we, as our consultants, are dedicated. And the consultant plastics was only present in almost less than half of the cases, which means that they usually send the registrar, or even they do not present, or they depend on the consultant ortho if he was able to close the wound, or to put like a vac dressing, or to cover the wound by any means, because they usually, what they think about is just like they will not go and cover the defect in the first instance. They usually will be coming and seeing the patient in the future. They will dealing with either a graft or flap, whatever it is. But that's why maybe this is the relevant. They are just presented less than 50% in the orthoplastic, and it's very important that they should be presented during the first look for the case. So what was the surgical pathway? The surgical pathway, the most patient required just one operation. Two-staged and multi-stage surgery were less common. It means that you might be fixing the open wounds just by definitive fixation and the covering of the wounds, not as we thought we just need a staged fixation or something like that. Sometimes you can go directly and just fix the patient and do coverage, if for sure it depends about like the kind of the open fracture or the type of it. Fixation strategy, definitive fixation achieved in 2 out of each 3 cases. External fixator were the preferred provisional methods. Plates and IM nail dominated final fixation for the choice. So also the IM nails can be still used in open fractures, and the plates, so it doesn't mean that you need to put the patient for a long time in an external fixator. You can directly use a plate on IM nail after you took off your provisional methods, as if you felt like the patient is stable and he passed all the events that might be happening after his initial trauma. Soft tissue coverage, 60% had bone fixation and coverage in the single setting, which is a really promising one. Stage coverage involved advanced technique like free flap and grafts. Antibiotics, nearly half received the antibiotics after the wound closure, median 3 days. Average hospital range stay was from 8 to 10 days. We need to talk about that nearly half received antibiotics after the wound closure, median was 3 days, because some of the trusts, if you went and have a look for the open fracture pathway for the antibiotics, some of the trusts, or I'm going to talk about Addenbrooke's and Cambridge, they usually, again, is given an antibiotics after the initial fixation. If you fix the patient, if you have added any coverage, if you give like a teicoplanin and gentamicin, you don't need to give any further doses. So there is no need to give further antibiotics for at least like 2 or 3 weeks, like we know from previous practice. We don't need to make the patient continue on antibiotics. The average hospital stay was out from 8 to 10 days, which is it's really good one. It's not bad. And almost half were discharged in a fully web-bearing ability. So also, if you had an open fracture and you fixed the patient by nail, there is also still a post guidelines for web-bearing status, which shows that the patient might be able to fully web-bear after you had introduced your IM nail. So there is no need to say that this is an open fracture. It needs to take long time to fully web-bear. So the discussion and the scope and the impact, we assessed the care across all the open fracture types, not just the lower limbs, which is a really good one. So usually we thought like if I got like an open fracture, usually your mind in automatic way goes for the tibia or the femur, but we still have an open fracture for the forearm and all the other fracture we can have. So this study have shown across all the open fracture types, there was a strong data integrity, 91 completeness enabled full pathway evaluation. There was some gaps, which is less than 25 received antibiotics pre-hospital. Timing in the ED is highly variable, so that's why they are trying now to push for the 4 hours rule and things like that. So they are trying to push the patient to have the scans as quick as possible and to be moved to the theaters or to be allocated to a parent team. 18% of the transferred patient has been missing antibiotics the pre-transfer, which is, I think it's you can improve that if you ask the ambulance crew about the antibiotics, so you make them aware. For sure they are aware, and sometimes in a major trauma center there are doctor transferring the patients by helicopters so usually they are aware that a lot of medication has been given for the patient, and for sure one of those as antibiotics should be given. 47% continue antibiotic post definitive closure, which is also is not indicated. So 50%, almost 50% of the patient who had the closure, they still continue to have an antibiotics. This is despite might be the guidelines stating that there is no need for antibiotics after the closure of the soft tissues. Surgical timeline and team coordination, median time to the surgery was 16 hours, which is not bad. It should be about between 12 and 24 hours, so we're still in place. Daytime operation, senior ortho present in about 90%, the consultant surgeon present in only 45%, combined orthoplastic planning as per NICE and post guidelines often not achieved. So usually the plastic team are not aware about what you are doing. You sometimes just give them a call while you are the patient on table. If you are a good registrar, you will ask them to come and assess the patient in ED. Most probably they will not be free to come and see. So that's why it usually flipped between your fingers, and that's why maybe this is the reason for the low kind of numbers we can see here. In about 42% of the procedures, no plastic surgery attendance. So they are emphasizing this one, and they usually speaking about that. Pre-operative discussion between orthoplastic was only 37%. 20% of patients lacked documentation for the MDT discussion between the orthoplastics. Lower limb cohort reflects similar deficits, refuting hypothesis that fragility injury skew the results. What's the clinical impact for that? If you don't got like an MDT, absence of the plastic input may hinder the optimal fixation and coverage planning. Lack of this MDT violates the national standards, emphasize the need for systematic change in communicating and team-based planning. The conclusion for that, the open study highlights a strong surgical timing adherence, which is good, but reveals shortcomings in the antibiotic practice and the combined surgical oversight. Reinforces that the importance of coordinating between orthoplastic care for the best outcomes. So regarding, they spoke also about the implant and the fixation strategy. As we do mention before in our brief, that the implant had a minimal impact. 60% have received fixation coverage in one operation, which is a really good one. Almost 94% managed with simple suture for skin closure. So just like wash out and simple skin closure. And for the negative pressure wound therapy, like the VAC dressing or whatever it is called, is still commonly, or Krakovac or whatever it is, still commonly used. Despite there is a Wolfe trial showing no benefit, but still being used. Okay, I've seen it like in all the MTC centers is still using that, and they emphasize the importance of that. And I'm not in a position to see what's the Wolfe trial. I haven't seen it to say if that had a direct impact on my decision or no. 70% of the open tibia fibula fractures temporized with a negative pressure wound therapy. Median time for definitive cover was about 87 hours, exceeding the guidelines. Delayed closure effects unclear, needs further study. Web bearing, 50% of the lower leg patient were non-web bearing, and the median hospital stay was about 9 days. So what's the take-home message? The take-home message is the open study have achieved more than 90% of the data compliance, offering an accurate, comprehensive snapshot of the UK open fracture care. Antibiotic stewardship, it was nearly half of the patient continued to have an antibiotics for a median of 3 days post-definitive closure, highlighting the need for tighter and adherence to the prescription guidelines. Orthoplastic collaboration, it needs a consultant plastic surgeon, was absent in more than 50% of the initial deployment, underscoring the need to improve the MDT planning between the ortho and the plastic team. Okay, so that's all from my side. Any questions?
Hatem, thank you so much. Very well presented, and you've shown your experience with the MTC practice for open fracture. Guys, it's a hot topic, so open fracture is very clinically relevant for all of you. So post your questions in the chat, so Hatem can answer it for you. Who don't have like MTC experience, Hatem can help you with what they are doing day to day. Hatem, it seems it was a very clear presentation, so we don't have any questions so far.
Okay. I might just make it in 2 minutes. So let's remember what was our standards of treatment while before we coming here to UK regarding the fixation. Maybe one of the juniors colleagues just starting his career in like an orthopedics, and he might be have some benefits from that. So usually if you got like an open fracture, first of all, don't panic. Okay, so when you see like a mangled extremity, when you see like the femur is outside, the tibia is outside. So the first thing you need to understand that your main priority is just to save the limb. Okay, don't worry about the bone; it will heal. We will try to save it. But the first thing that the patient need to be alive, because this open fracture might be ending the patient life. Okay, so the first thing, don't think only about the bone. Think about the patient. Think about the lactate. Think about the patient if he had like a head injury, if he had other internal injuries. So think about the patient as a patient, not think about the patient as just like a bone. This is the first thing. Second thing, it was also a mistake that we used to have an X-rays prior to reducing any kind of fracture, which is not right. So you need to reduce first, back slab or what's as a temporary fixation, whatever it is, and send the patient to the scan. Okay, so don't assume that you need to have an X-ray and you leave the tibia outside the bone for half an hour and you just cover it with a soaked gauze and you feel like you have done the perfect thing for him. Second thing, you need to have some pictures. You have to document the neurovascular structures. It's very important that if you Google it now, it's the post the guidelines. It's really informative. It's really applicable wherever you are practicing, like anywhere you are practicing. It will gives you only the thing that you need to go and the things that you need to make it adhere to your brain while you are seeing a patient with an open fracture. So I'm happy to receive any question, and that's all from my side. If Mr. Hashim, you want to say something, I'm happy.
Thanks, Hatem, again. So, yeah, that's very clear. So I think, to be honest with you, we didn't have a guidelines back home. So it was a very aggressive treatment. So I'm maybe a bit older than you. So all days what we do, so we receive the patient. We never panic because we have 4 or 5 of them waiting in a queue. So I work in Mansoura, so Mansoura University Hospital. So we have emergency hospital, which is super busy. So 4 or 5 open fractures in an hour. So, and we make a big mess in the ED, washing them, reducing them, putting a lot of dressing, antibiotics, getting them. We had like first floor operational emergency. So we get them there and do a debridement, and was a very bad practice, to be honest with you. A lot of infection. Most of these guys in by frame or even losing the limb. Yeah. The guidelines is very in UK is very very valid, very relevant, very reliable. And I've worked in MTC in QE in Birmingham, and approach was very very professional, and I think the results are very good. So definitely everyone needs to familiarize himself with, even if not working in MTC, because this doesn't mean that you will not receive an open fracture. And you need to know how you will firstly do a first aid for the patient, and then even if you see this at the scene. So there's a very valid course called ITLS, which is immediate trauma life support. I'm an instructor in this. It's mainly directed to the personnel, to the ambulance personnel and the paramedics, but I found it very valid to attend. I've attended as a candidate firstly, then an instructor. So it gives you an insight how to deal with this patient in scene, and then at hospital, how to hand over, how to keep the patient stable and safe until he reaches the hospital. And definitely if you work on an MTC, so this is your day-to-day practice. If you don't, you need to familiarize yourself with the guidelines. It's not only the journal club. It's a very common question, or few questions in part in section 1, and very common station in section 2. So you will face it in section 2 100%. So you have 6 trauma scenarios, at least one, if not 2, is damage control and ATLS. and open fracture. So no, it's very, very important. I think you covered it very well. You've shown your experience. You make it more of a practical approach rather than just a journal club and a paper appraisal. So well done for that. And
Thank you
for your time and for the effort. Guys, if you have any questions for Hatem before we conclude. It's one, to be honest with you, it's one of the missed practices in UK. After some time, you get descaled of dealing with these hot cases, open fractures, mangled limb injuries. But no, it's definitely worth trying it. That's why it's an integral part of portfolio pathway application. So any one of you planning for Caesar, he has to spend at least 6 months in one of the MTCs. So if you haven't done that already, put this in your plans. So not to get surprised at time of the portfolio pathway application.
Yeah.
So yeah, MTC is a must. And to be honest with you, it's a fair game, because without an MTC experience, you're missing a big part. And you're not ready to deal with these cases, which is very critical cases with minimal golden hours. Good, guys. From next month onward, we're still running our monthly journal club very regular for you to keep up to date and for your portfolio and applications, because regular journal club attendance is one of the evidence to show that you have a research experience. So at least 6 journal club a year is a must to show that you have a research experience. We're running this for you, so it will be running on Zoom. I've shared the link in the chat. You need to register for that if you want to get that certificate. If you don't want to get a certificate, it will be live for everyone and it will be recorded on my YouTube channel. But for a certificate, you have to pre-register on the link there, and we'll be running the same every second Friday. This time only because mid-all will finish on 11th of July. That's why we have to do it today. But later on, it will be very regular, second Friday of the month at 7 p.m. London time, 9 p.m. Cairo time. We'll post a schedule for you for the next 6 months. It still will be running by you. Every month we have a subspecialty team, and in 6 months' time, we'll move from subspecialty. Now we're doing a journal theme. We run from that to a structure theme. So we'll be doing like trials only, then doing RCTs only, then doing systematic reviews only. We need the journal club to be very, very, very divergent everywhere, and to cover every and each bit. Mo Shalan will be sending you the schedule for the schedule for the next 6 months. Pre-registration link for Zoom is on the chat. Certificate from mid-all today will be posted to you by email if you fill the feedback. And definitely from next month will be the same certificate will be coming to you once you fill the post session survey and you already pre-registered. So please do all register to the Zoom meeting. We'll remind you by before a week before the journal club. We'll keep a lot of posts on Facebook and WhatsApp, and hopefully it's helping for all of you and you feel it beneficial. Thank you so much for everyone for attending. Thank you everyone for spending time on us. Thanks for
Mr. Hashim, sorry.
Yes.
My colleagues, if anyone has missed any certificate, any speaker certificate, any attendee certificate, just please text me and I will do it for him. And please submit the feedback for today certificate, please.
Yeah, more for the attendee, for the speakers, yes. For the attendees, mid-all does that. All what you need is to go back to mid-all, fill the feedback, and he will send you a certificate straight away, automatically.
Yeah, but even if from previous sessions also, if
even previous session, if you go to previous session, he can do from his email. Yeah. For the speakers, yeah, if anyone missing any certificate, just send to Mushalan, and we'll generate you a certificate for. Thanks, Mina and Hatem, for the presentation today. Were very good and thorough, and I think was beneficial to everyone. They got the message from the Wrightington classification and from the open study, and hopefully every one of you will have a good evening, and see you next month will be the 8th, yeah, 8th of August. Okay.
Okay. Thank you.
Thanks, Hatem. Thanks, Mina. Thanks, Mo.
Thanks, everyone. Thank you.
Bye.